into our programming today to let you know what happened yesterday in our steering committee meeting. So the steering committee is the leadership of the coalition, and we gather together and kind of talk about how we're going to do things and move things forward. There are 4 founding members of the coalition, DHHR, and Craig had a update from them saying that the Comp Cancer grant award had been confirmed. That's good news for us because that's the grant that is under, that Mountains of Hope is under. It's going through its technical review right now. So yes, good news. BCCSP, which is the West Virginia Breast and Cervical Cancer Screening Program, is up and running. We are adapting to COVID. Folks are working from home. We're doing sporadically in the office, but we are still enrolling women. We are screening women. If you don't know what that program is, it provides free and low cost breast and cervical cancer screening to women who are uninsured and underinsured. And that is something that, you know, as we see these people out of work and losing their insurance, is going to be more and more applicable, I think. So we're trying to work with providers to get that going. West Virginia University Cancer Institute is working on multiple programs and adapting to work from home at this time. And then the American Cancer Society had a survivors program that was supposed to be live that they have now adapted to be an online webinar. And I'm going to try to share that. Oh, Lauren, I cannot share my screen.
You should be good to go.
All right, there we go. Can everyone see that? Yay, head shaking. So this is for the West Virginia Cancer Survivorship Resource webinar. It's going to be in June. There's links here for how you can register for the meeting, and there are going to be a couple of different sessions. That way it's not so much all at once. And we hope that if you get the opportunity, you'll take part in that. Other than the 4 founding members, I'll go ahead and stop sharing that now.
Also, Shelly, just to let everyone know, I'll send that out on the listserv tomorrow so everyone can see it, but we just wanted to introduce it here today.
Yeah. So when we talked yesterday, a lot of the times we have you guys fill out surveys and let us know what you think. We really do take that back as a steering committee and talk through what our needs are as a coalition and how we can help you. And one of the things that we've been talking about is providing more leadership training for those that want to step up and take a leadership role in the coalition. It's nice to have a little bit of training and support in that. And so Dr. Redmond Knight is going to do some leadership training for the steering committee. We're going to do 3 trainings with her. One is going to be on coalition burnout, so how a coalition will ebb and flow in its work and how to prevent burnout. Re-engagement, how to get people who have maybe been a part of things but then had to step away, back involved and bring them back to the fold. And then recruitment, because we have talked about trying to get more membership and more involved membership. So we're going to do those 3 additional trainings as the steering committee moving forward. Which also leads us into the other big thing we talked about yesterday, which is how do we continue to do our work? You know, with COVID coming about, we're all having to adapt. And so today's really kind of our test run of, can we do large membership meetings online through Zoom? Does this work? How do we adapt to that? And getting your feedback for that's going to be, again, really important. With the work groups today, that's one of the things that, you know, you're going to have to look at as we start looking at how we're wrapping up this year and getting ready to move into our work plans for next year, is how are we adapting to the situation with COVID. And then the last thing we talked about was just kind of putting out there the idea of putting together a nomination committee so that we can get a little more, normally we say, hey, who wants to run? And then we kind of go from there with our elections. We're looking at making it a little more structured and providing some more background of, if you're looking at taking this position on the steering committee, here's what's going to be asked of you. This is what you're agreeing to, and providing a little more support that way. So Summer is going to be talking to folks about, if you want to be a part of that nomination committee, how you can be involved and work with that. And that is what your steering committee did yesterday via Zoom. Lauren, did you have anything you wanted to add?
I think Summer has something she wants to add from the membership committee.
Okay.
All right, folks. So there's a few things. First, I just want to let you guys know we did have a survey go out earlier this week, maybe at the end of last week. All time runs together now in pandemic world, and we are just wanting to do a membership satisfaction survey, figure out how we can improve, what are we doing well. So please take the time to fill that out. The responses will be confidential, so please be honest. Additionally, I am the chair for the membership committee, and so we are in the process of trying to revamp our membership and figure out, new ways to move things forward and build up our coalition. So essentially, it's dedicated to improving member engagement and membership recruitment. So if you're interested in serving on the committee, please reach out to me. We meet about once a month via Zoom, and then we do in-person meetings during the quarterly membership meeting. So it's a great opportunity. You get to work closely with myself and Lauren, as well as 3 steering committee members. So please feel free to reach out to me, and I hope you'll be a part of our committee.
Thanks, Summer. Okay, Lauren, I think we're ready to start with our first presentation.
Okay, well, our first presentation this morning is Sally Hodder, and she is the director for the West Virginia Clinical and Translational Science Institute and the associate vice president for the Clinical and Translational Research team. And we are happy to have her today. We snagged her last minute, and she generously decided to come on and give us some information about COVID-19 and West Virginia's response.
Thank you, Lauren. Can you hear me?
Yes.
Okay, I'll try to share my screen. Can you see that?
Yeah, that's working.
Okay, well, I want to thank Lauren, and I want to thank Dr. Kennedy Ray for inviting me. I have been in infectious disease actually for 35 years, actually longer than that. I was an intern in San Francisco in 1980 at the dawn of the HIV epidemic. And so despite the fact having lived through the HIV epidemic, I have never seen anything like this. And so what I thought I would do is talk a little bit about this and all the things that are going on in West Virginia. And I've really been very, very impressed. As you know, we have just seen this now just spread all over the world. Actually, the hottest epidemic right now is in Russia, and it's coming back into China from the Russian-Chinese border. Almost 95,000 Americans have died. I thought I'd sort of talk about those things. I won't read the list and finish up with the West Virginia response, though I want to weave that throughout as we talk about some of these things. Just a little bit about coronaviruses. These are a really, really large family of viruses. Historically, they have been responsible for about 25% of the common cold. But, you know, starting in the early part of the 21st century, coronaviruses emerged from animals to really cause serious human disease. From 2002 to 2004, there was the emergence of SARS-CoV-1 at that point. It emerged in Hong Kong, and that was followed. It came up and went away, and we never really understand why it didn't become a pandemic. There was a lot of anxiety at the time, but it never really spread much beyond Hong Kong. There were cases in Toronto from travelers, but never caught on. The second was the Middle Eastern respiratory syndrome, or MERS, that emerged in 2012. It also was a relatively self-limited epidemic, though to this day you can actually isolate the virus from camels. And then, of course, in December of 2019, there was the first reports of severe acute respiratory syndrome in Wuhan, China. And just a note on terminology, the SARS-CoV-2 is really the official name of the novel coronavirus causing this, and the disease is called COVID-19. If we look just at mortality rates, of course, you know, many people have died from SARS-CoV-2, but compared to some of the other mortality rates, SARS-CoV-1 was about 10%, and MERS is actually a third of folks die. So these are very serious viruses that cause a lot of morbidity and mortality. If we look genetically, SARS and MERS are related to the CoV-2, but CoV-2 was really a new virus emerging from an animal reservoir. Really, the available coronavirus sequence data was determined, and there were a lot of concerns, and sometimes you still hear them in the press today about, did this originate from a lab? And there have been several really good papers that have looked at the backbone molecular structure, and it really appears that this virus came from bats, which is where we believe SARS-CoV-1 came from. This one actually probably passaged through pangolins. I didn't know what a pangolin was before this epidemic, but it's an anteater. And this CoV-2 virus, the spikes on it, you can see in this picture, these little, spikes around the perimeter of the virus. That's where coronavirus takes its name, because it looks like a crown. And these spikes bind very avidly to what are called angiotensin converting enzyme 2 receptors that are found in the lining of the alveoli of the lung, but are found in other places as well in the body. And it's really believed and it's a very tight affinity between SARS-CoV-2 and these ACE2 receptors, which is felt to be responsible in part for part of the transmissibility. As you've all heard, respiratory droplets and aerosols are the major way this virus is spread, and this is really an enhanced photograph of respiratory droplets coming out with a sneeze. They actually did time delay, and actually, if you look out for minutes, some of the smallest particles can persist to 8 to 14 minutes. And, that is why I think it's so important with the emergent advice in this country to wear a mask. And what that does is you're really sort of protecting others from these respiratory droplets and aerosols. And just if you talk or, certainly sing, there are a lot of these. Fomites, the things you touch, I have a slide in a minute that shows how long the viruses can live. This is really felt to be a less efficient way to transmit. Nonetheless, and I think over the past couple of days, the press has really said, oh, this isn't so important. We've always known it was a minor way that it was transmitted, but nonetheless, that virus is a sticky virus. And if you get it, touch something, get it on your fingers, don't wash your hands, and touch your nose and your mouth and your eyes, which we all do multiple times a day, that is really a portal by which it can get in. The next slide is from the CDC that just illustrated an epidemic, a cluster at a choir, where one of the folks was infected and 87% of the group developed COVID-19. And I think if you think of the previous slide, you can understand with singing why there would be a lot of respiratory droplets. This is really the slide that shows that the virus is really viable. This came from the National Institutes of Health, up to 24 hours on cardboard, but 2 to 3 days on plastic and stainless steel. There has been some concern whether or not this virus could be transmitted by the stool. In fact, though, if you do a PCR, polymerase chain reaction, which is one of the diagnostic tests that looks for pieces of virus, they have found positive PCRs in stool, but almost all of those samples have not been viable virus. And fortunately, to date, it doesn't appear that there is a efficient perinatal transmission. They've looked in amniotic fluid, cord blood, and breast milk, and have not found it. Given the fact that social distancing, is so important, and now we're starting to open up, I thought that this was really a relevant slide that takes us back to the last great pandemic in 1918, which was influenza. Influenza is a different virus, but nonetheless is a respiratory virus and is easily transmitted. And what the picture is a Liberty Loan parade that was really generating money and support for the war effort. That took place in Philadelphia on September 28th. They started to see cases September 17th in Philadelphia, if you look at the panel on your right. And the parade occurred on the 28th. Social distancing in Philadelphia was not enacted until October 3rd. And you can see the sharp increase in surge in cases versus what occurred in St. Louis, where social distancing was put into place very quickly. I think West Virginia has done a good job. The schools were really sort of shuttered in mid-March. And I think, and this is as recent as this morning from the DHHR, you can see that our curve looks much more like the curve from St. Louis rather than the curve from Philadelphia. So this is all to say that I think social distancing works. I think that this virus is going to be with us, and social distancing is going to be very, very important for some times. If we go to the next slide, the symptoms, most people have fever, though I would caution, many people early on don't have fever. That can occur after the first couple of days. We know that this virus is transmitted even before people become symptomatic. Some people never become symptomatic. And so with all the temperature checks and everything, I don't think that's the be all and end all. Obviously, cough, fatigue, myalgias, shortness of breath are other symptoms. Given the new virus, I got to tell you, every week we learn something new. And it's really apparent that this is much more than just a respiratory virus. There have been multiple dermatologic manifestations. The most common one you hear about are COVID toes, usually in younger individuals. And biopsies have actually showed some clotting in dermal blood vessels. There was a paper in the medical literature in April that the virus appears to attack a thin layer of cells that line vessel walls and then can predispose to blood clotting there. And in fact, large vessel strokes have been reported in persons in middle age, less than age 50. And just over the past 2 weeks, you've probably seen on the news a Kawasaki's-like syndrome that's reported in children is now called multisystem inflammatory syndrome in children. It usually occurs, after children have had the virus. Sometimes their antibodies are positive, but the polymerase chain reaction is negative. You can see the symptoms there, which can be very severe, and it can include shock, and ultimately can include aneurysms of the coronary and large vessels, which is very, very serious. And more than 100 cases have been reported in New York. It was first reported from the United Kingdom. And one of the very, very interesting things that is not figured out is that this syndrome has not been commonly reported in the Far East. And there is a question, is there some genetic predisposition? Is the virus a little bit different as it's sort of migrated around the globe? And those are questions that we don't have answers to. There's also been reported involvement of kidneys. This was an autopsy series, and roughly 1/3 of patients had involvement of the kidneys, with 7 having coronavirus in the kidney. And as you've seen from multiple reports, it is folks who are older that really have the highest fatality rates, with individuals greater than 80 having case fatality rates that really are greater than 15%. That's not to say that there aren't deaths in younger age groups, and there certainly are, but not with the frequency that you have in older folks. This is an older slide from New York that looked at comorbidities, and you can see that more than half the folks had hypertension. And these were, 86% of the state's deaths at that time, and this was early in April, involved at least one comorbidity. And you can see the others there as well. If we look at fatality in West Virginia has a case fatality rate, and this was pulled again from the DHHR site this morning, of 4.4%, a bit lower than the US average, but a bit higher than Virginia and some other states. I think there are multiple reasons for that. I think if you look what happened in New York City, the healthcare system was completely overwhelmed. And I think that the availability of good supportive care and ventilators and so forth was compromised, and that may have contributed to a higher death rate. Now, if we look at diagnosis, and this is just really a generic cartoon, but you see the red spikes, the coronavirus entering the body and establishes infection, and it takes, usually a week or so until the body starts to generate antibodies. Hello? We still good? Sorry about that. And then subsequently, there is an immune response, brings the virus under control, and the polymerase chain reaction, which is the major way acute infection is diagnosed, which is positive over here, then becomes negative, and then there are antibodies that occur. Now, the way the disease is diagnosed, the acute disease, is with a polymerase chain reaction. There were initial glitches in the availability of kits from CDC, which I think really delayed the testing response, and you probably read all about that. More recently, the commercial labs have come online. They're now drive-through testing sites. Though, this is really not solved yet. And in fact, as of a couple days ago, results from Quest were actually running days out again, and it was increasing. And part of the issue, I think, is, the number of tests that are coming overwhelming the infrastructure to run those tests, but also part of it has been the limited availability of the swabs. It's not just a Q-tip. You have to use a swab and really swab really far up in the nose. And let me just take a minute to say the West Virginia response here. The College of Engineering is actually working with Forms Lab, has procured 3D printing availability, increased availability, and is printing 3D swabs that are right now being tested to, establish that they actually can diagnose the infection as well as the standard of care commercial swabs that are available. And I think that that's going to be very, very important. The second thing is that polymerase chain reaction, one is being developed in the Health Sciences Center. And the hope is that this will actually be able to be automated, providing additional capacity for West Virginia. And they're also looking at being able to pool samples. This virus, we're under 2% positive now, which is not, sort of very great. So to test every sample separately takes a lot of time. But certainly if you could put a couple hundred or 1,000 together, if it's negative, they're all negative. If it's positive, then you have to go back and figure out which individual is positive. But I think that that is really going to contribute in the future to West Virginia being able to have really enhanced testing capacity. Just going back to this cartoon, the measurement of antibodies is really the serologic response. You've probably also read in the news, there were lots of antibody tests that were available. Some of them have not been accurate, have probably been measuring cross-reactivity for other coronaviruses. And so the FDA and the CDC are attempting to really validate, and some of those serologic tests have been taken off the market. I will say, though, what we don't know yet is whether or not those antibodies will provide protection against future infection for individuals who have recovered from the infection, and if so, how long that will last. So right now, the idea that you get tested for antibody and you can consider yourself immune, the science is not there. And that is something that is really under intense investigation. At WVU, Heath Dameron has developed a serologic test, and it is being validated and looking at very, very carefully. And one of the ideas is that we really want to understand what the prevalence of past infection has been from the point of view of so we can understand the epidemiology in West Virginia and the proportion of individuals who never had symptoms and yet had antibody indicating that they had the infection. I should say that Dr. Dameron's also working in vaccine development. I'll talk about vaccines in a minute, and I think that that's very important. And also, he's working on being able to determine antibodies with a finger prick test. So if we're trying to do surveillance and figuring out, what the prevalence of infection has been, to get a tube of blood from everybody, you all know what that is. That's a bit more difficult as opposed to just simply being able to do a finger stick, getting a very, very small blood sample that then can be tested in the capillary tube. So those are some of the things on the, sort of horizon in West Virginia. I just wanted to take a minute for treatment. Hydroxychloroquine has been all over the news. This is a paper from this month in the New England Journal. It was a retrospective cohort series. It was not a randomized trial. Nonetheless, individuals who got chloroquine versus those who didn't did no better. And it was a well done paper. There were several thousand folks. They did matching to make sure that the comparisons, had folks of equal disease severity and so forth. The National Institutes of Health is initiating a randomized controlled trial. So I think that really the jury is still out, but the early evidence would indicate that it does not appear to be effective. The drug, though, that did provide some promising data that you probably heard about is remdesivir. This is a directly acting antiviral drug, was actually developed for Ebola and was not effective in Ebola, but has been shown in the test tube to inhibit RNA synthesis of SARS-CoV-2. And NIH released some results. They've not been published, but it shows that the days to recovery really decreased from 15 to 11, which was statistically significant. And mortality, it decreased as well from 11 to 8.3%. And though this was a trend, it was not statistically significant. The p-value was greater than 0.5. And finally, the Data Safety and Monitoring Board, looking at the remdesivir trial, when they saw these trends, they stopped it. And remdesivir is being made available to all the states, though it is relatively limited. We've been contacted to actually initiate a randomized study here for people with severe pneumonia with remdesivir, as well as with an interleukin-6 inhibitor that, there's some thought that perhaps some of the severe morbidity and mortality are due to really cytokine storm with high levels of IL-6. And if you could inhibit that along with an antiviral, would you improve outcomes? And hopefully that will be coming to West Virginia soon. Convalescent treatment. This was a paper from the Chinese, and there were 5 critically ill patients, all recovered when given convalescent treatment. Convalescent plasma, what it does is it really takes blood and isolates the plasma, which has the antibodies in it from individuals who have recovered from COVID, and then that plasma is given to individuals who are ill. And Dr. Peppers actually has an FDA investigational new drug certification to do studies of convalescent plasma in West Virginia. I just wanted to finish up with prevention, and obviously I think a vaccine is what's going to be critically needed to really ultimately end this pandemic. This slide just shows you, I think, back in the days of SARS in 2003, it really took us 20 months to identify and get the genetic sequence of that virus. And as you see, the Zika virus in 2016 was 3 months. The coronavirus was actually first reported from the Chinese December 27th. By January 7th, they had sequenced the virus and made it available to the world. I was at an NIH meeting at NIAID on January 18th, where Dr. Fauci had announced that they actually had vaccine candidates, and on January 18th, it was already in laboratory animals to look at safety. And this 2 months is really the time until it's into human volunteers, and indeed that was on the money. It went into human volunteers. This is the NIH vaccine in March, and they have recently announced this week that there was immunity produced, and a phase 2 study is being planned. There are about 100 vaccine candidates throughout the world. You might have been reading about the one from Oxford in the UK, which is also going into human trials. Actually, 7 of those vaccines are now into human trials. So I think that it's really been lightning speed with which vaccines have been developed, just due to our better understanding and better techniques, molecular techniques. Just to end up, prevention, masks, we talked about that, hand washing, sanitizers, cleaning surfaces with effective disinfectants, social distancing, and testing, contact tracing, and isolating. And I think that the issue is that the testing has to increase a lot. And in fact, 20 to 80% of folks are estimated to not have symptoms unless you do surveillance testing. You know, we're not going to have an idea. The idea is not so much to identify it after we have a peak or a cluster somewhere, but to be able to predict in West Virginia, you know, where we need to perhaps be a little more careful, have more concentration to social distancing, and certainly intense contact tracing and quarantine. This actually just shows the number of tests per the number of positive individuals. And, you know, I'll just point out the US, for every test that, or 8 tests that are done, 1 person is positive. And that really contrasts to places where you really have more control of the virus, like South Korea, where, you know, 69 folks are tested for every person. And this just makes the point that we're going to have to really increase our testing, which brings me to my next and last slide, which is the West Virginia response. Number one, we've established a West Virginia registry to look at predictive factors for disease severity. Are they different in rural areas and in West Virginia? We're actually working to become part of a larger NIH registry as well, so different areas of the country can be compared. We're looking to do convalescent antibody, again, to look at how much infection has been out there. And those, as I mentioned, Dr. Damron has an antibody that looks very good and is being validated. I mentioned the swabs. If we're going to anywhere approach the number of tests that we need to do, you know, we are going to have to get our own supplies, and hopefully these 3D printed swabs will be a partial answer to that. Various models have suggested that you have to effectively have surveillance test 0.067, so less than 1% of your population per day. That translates to 12,000 tests in West Virginia, and we are nowhere near that now. So we really sort of are going to need this. I talked about the PCR being developed here. I didn't talk about mass decontamination. As you know, there's been a lot of issue with the supply chain and getting N95 masks. And the folks at WVU have actually used vaporized hydrogen peroxide, have tested it, and can effectively decontaminate the masks. They're being very careful and looking to make sure that there's no deterioration of those masks in their ability to seal. And they are actively decontaminating masks now for the West Virginia National Guard and others. I talked about the serologic testing. We have some interesting studies looking at the genetic basis of severe disease. Why do some people go to the unit and die? And why do others, you know, absolutely have no symptoms at all? We don't understand that. We don't know if it's the virus, if it's underlying genetics, if it is really the amount of virus you were exposed to, or all of the above. And those studies are all ongoing. And then lastly, really monitoring, I think, as an early warning. We have a modeling group that is looking at not what the incidence is today, but what the curve looked like a week ago, and looking through Google publicly available data. You can look at the amount of movement of people and population density. And we're trying to look at some models that'll say, you know, a week down the road, this area may be in trouble. We should really sort of test. And I will, I have a conclusion slide, you know, and I'll stop there. I just want to make the main points. This is really a new virus. We are learning new things every day. It's not just a virus that attacks the lung. The remdesivir is an effective treatment, but it's not a game changer. I think it gives us some clues where to look in that virus to target. Vaccine is proceeding rapidly, but there are multiple potential barriers, and every time somebody on the news says, I think we're going to have an effective vaccine in the next couple of months, I wince. I hope I'm wrong, but I think it's going to be a little more difficult than that. social distancing, critically important as are the other things there. Testing and contact tracing. And I think contact tracing, not only the old-fashioned way by people going out, but perhaps looking at some of the newer electronic methods, respecting privacy. People can opt in or opt out, but I think we really have to use technology on this one. And really, I think the West Virginia response is really going a long way. I've really actually been impressed, and I can tell you, friends I had at other institutions, I don't think there's a lot more going on at a lot of other places. So I want to thank you for your attention. I'll stop there.
Thank you, Sally. We did have somebody who asked a question in the chat while you were talking about masks, and said there's a lot of information going around whether we should or should not wear the mask. Do you have some information on that?
The recommendation is individuals in the community, and I'm not talking about healthcare providers who, of course, there's personal protective equipment recommendations for the CDC, but in the community, cloth masks are recommended. In that slide I showed with all the respiratory droplets coming out, you can understand that the mask would really keep those in. Masks have been compulsory in Japan, and while I'm not suggesting that, if you look at their death rate, it is much, much lower. And folks have predicted that if masks would increase in this country, and be very clear, what you're doing by wearing a mask is you're protecting everybody else. If half the people don't even know that they may be transmitting virus, you can understand why you'd really want to, keep the respiratory droplets from, circulating. So it is being recommended that individuals in the community do wear masks. Obviously, if you're riding alone in your car and nobody else is in the car, there's no reason to have it. But I think, if you're in the grocery store or places where, you're wearing a mask could protect others, I think it's really essential.
Sally, it's Stephanie. Thank you for a great presentation. I wanted to quickly ask, for Cancer Coalition members, what is it you think we could contribute to the West Virginia response?
That is a great question. And I think, the Cancer Coalition are individuals that, really understand how important health is and prevention is, and, making sure that folks are getting appropriate diagnosis and treatment. And I think often coalitions such as the Cancer Coalition, have a lot more credibility than somebody, sitting in a university saying something. So I think that the important thing for community members is to be able to, take in the information and then communicate the points that they think are important to other community members. And I think that often coalitions are much more effective than academic institutions.
I have a question, if I can ask one. This is Susan Eason. Thank you again very much, Sally. This was very informative. This weekend, there's around the state, different health departments are offering free testing, and they're focusing on minorities and uninsured and vulnerable populations. And hopefully those folks are going to get out. I'm wondering if, is it appropriate for people who may not be in that category also to be tested, even if there are no symptoms? So I'll leave it at that.
Yeah, well, it's a great question, Susan. Thank you. I think clearly there have been reports of increased mortality, particularly among African American populations. And so I think that the health departments are understanding that, testing is limited and they want to target those individuals at greatest risk. But I would add that I think ultimately we are going to need surveillance testing of well folks in all of these communities. And I think that that would be, you know, clearly the direction we need to go. Having said that, you got to start somewhere. And I think that West Virginia, again, the response really testing residents of chronic nursing facilities and their staff was a big start. You know, subsequently testing daycare centers, and then really testing vulnerable populations. So those are all great places to start, but I think ultimately, as supplies become available and the throughput is increased, we're really going to have to greatly increase surveillance testing.
Great, thank you. And then we did have one other comment from Megan in the chat, and she just was wondering if the effect on the toes might exacerbate people with diabetes and their own potential foot circulation issues. So just kind of a thought there.
Yeah, no, that's a great question. I don't think we know 100%, you know, with this virus. I will say that the individuals, like I said on the slide, that have been most commonly reported having COVID toes, for example, are younger individuals who may have had very, very mild disease. And I think, you know, as we have patient registries and can start to look much more effectively how many of those patients had diabetes, you know, we will have a better answer. One of the concerns, obviously, with diabetes is that you have an increased incidence of peripheral vascular disease, you know, getting blood to the extremities. And if you superimpose upon that vascular insult from the virus, will that make it worse? You know, one would think that that is a likely possibility, but to my knowledge, that has not been, you know, really rigorously demonstrated.
Sally, thank you very much. We appreciate you taking your time out of your day and really answering our questions. We are coming up on a time frame, so we have a poll to do, and we want to thank you very much for your time.
Okay, I just want to thank the Cancer Coalition for all the great work you guys do, and you know, you're terrific, and thanks for having me.
You're always welcome.
Bye-bye.
Thank you.
Okay, I'm going to put up Sally's polls, and you have about 2 minutes to complete that. Look at all those wheels turning.
Hey, Lauren, are you aware that on the last question, we can only check one?
There's an option.
Try to scroll down, Sarah Jane.
Okay, you have just a second left, and I still have about 9 people left.
Lauren, it looks like from the chat, a few people are having trouble scrolling, so you might not get 100% response.
I am, and it won't let me submit it. So sorry about that. I'm getting used to a Mac.
And I have no idea how to fix that. My apologies. I have no clue. Okay, we'll go ahead and end here. And okay. Yep, that's your timer going off. Okay, Shelley. Yeah, some people didn't even get the poll. That's so weird. Okay. Our next speaker is Dr. Jennifer Hancock from CAMC, and she's going to talk to us a little bit more about kind of the front lines of what's been happening. Jennifer, do you want me to share your slides?
Let's see. I've never done screen share. Let me see.
So if you just, yep.
Okay, I got it. Can you all hear me?
Yes.
Okay. I apologize. Our cameras aren't enabled on our computers, so that's why you don't see my face. I am the psychologist here at the Cancer Center at CAMC. So I'm going to talk about some changes in healthcare visits that we have done here and just some anecdotal evidence from my perspective working with patients, as well as stepping back and looking at some of the literature for pandemics and COVID overall. So we're just going to talk about those changes and then really think about how COVID-19 has affected our cancer survivor, our caregivers, and our healthcare providers coping. I think it's important to look at the spectrum because it's affected all of us differently. So in March, it was spring break week, and I came back to work after spring break, and we had all of these signs everywhere, and things really started changing that week. And it almost feels, I think, like we're in the twilight zone now, going to the grocery store with everyone in masks. And things have been very different. So here at CAMC, we aren't allowing any visitors to come in with patients, with some exceptions. We are allowing a caregiver to come in for medical oncology visits if it's their first appointment. And then if patients have dementia or Alzheimer's and aren't able to participate in their medical care, we can have someone. We have also made some allowances for end-of-life and end-of-life discussions. I know I've participated in some webinars for other states, and states like New York are not allowing end-of-life visitors in the room, and we are here. So, but things are different. We have, I think our medical oncologists have been very gracious. Our patients are allowed to have their phones on and can do speakerphone, so caregivers can participate that way and know what's being said in the visit and be able to participate and ask. As a state and a country overall, there's really been an emphasis on telehealth and a lot of webinars on learning how to do telehealth and the ethics involved in that, have been released for free, which has been really nice. A lot of the restrictions on HIPAA-related telehealth platforms have been, momentarily suspended, so we're able to actually do visits over the telephone and charge for that. A lot of people are using Zoom and other platforms and really looking into those HIPAA compliant. Here at CAMC, we're using 24/7, which is the HIPAA compliant platform, but not all of our patients have access to that or the technology to do that. So I'm still doing a lot of my visits over the telephone. Everyone who comes into our facility has to be screened at the front door. I don't think I've ever had my temperature taken so much in my life. And every day we come in, we have to wear masks, we take our temperature, we log that. all of our patients who come in get a mask. We've had really a lot of community members have been making masks and donating those, so we're able to have extra masks that we're able to give our patients to wear, and then they leave those and we take those home and wash them. But just very different now. We've also had to change our registration process. So, you know, before you would walk in, you would come to the main registration desk that is completely open. You would get a distress screen, which is paper pencil to fill out. Go upstairs, you get a pager. Because of the COVID-19 and worry about transmission, we're really limiting what we give to patients, what we pass back and forth. So because of that, we're not doing any distress screening. We're not giving pagers. We have waiting rooms are arranged so that people aren't sitting, you know, next to each other. The national, you know, guideline accrediting bodies have relaxed a lot of their restrictions for cancer accreditation. So even though we're not doing distress screening, we're not going to get dinged on that with this, you know, right now during, because I think everybody is scrambling and figuring out how can we best support our people while also, you know, doing what we can while we're still learning and figuring all of this out. For a long time, all elective procedures were delayed, so no well visits, no pediatric well visits, no screenings, no elective surgeries while we were waiting to see how is COVID-19 going to affect us in West Virginia, and are we going to have the resources available, you know, to do that. We're opening back up, but I know even for me, you know, all of my well visits are in March and haven't been able to go back to the eye doctor, my screenings yet. So all of that's been delayed. And then here at the Cancer Center, we have a patient resource center, and this is really our support place for our patients. So I'm a clinical psychologist. I see all my patients in my office here. We have financial navigators, nurse navigators, a social worker, chaplain, dietitian, but we are restricting access to patients. So all of our contact is over the telephone to really try to decrease risk to patients. So our resource center is closed, and that's because when people walk in, it's all open. We don't have a partition, a screen. It's just really harder to maintain that social distancing in an open area.
Hey, Jennifer, I'm sorry to interrupt you, but we are having some trouble hearing you. I don't know if maybe one of the options is to choose a mic. It maybe sounds like you have two mics on or something like that. There's just a good bit of background noise, I guess.
Okay. How do I, so
if you go to where it says mute, there's a little arrow up, and you can select the microphone and select the speaker.
So it says speaker, Realtek, high definition audio, or same as system.
Yeah, your Realtek should be okay. That's what mine's set on as well.
So if you just switch to phone audio.
Yeah, you might try that.
The other thing that can cause that warble is if there's a fan or an electric heater going in the room. Sometimes that can cause that effect.
And I don't know how to stop that one.
I can send you the call-in number if you want to try that. It's up to you.
I have it right here.
Okay, perfect.
Sorry.
And that's okay. And I'll go ahead and share. Well, I can share your slides if you want, or you can still share them. I don't think you calling in will affect that at all.
Sorry, let me try again. I didn't do the meeting ID right.
And just in case somebody else's, everybody try and mute theirs. Maybe somebody else's sound is on and that might be affecting it as well. So.
What is the meeting ID? I'm in it, but it's not taking the whole ID.
Okay, so the meeting ID, 1 second, is 961
Okay.
6746 4793.
These little technical assistance breaks are a great time for everybody to stretch.
Okay, I'm on hold by the host, so I need to be released, I think. Am I here?
I hit admit.
Okay.
Can you hear me now?
Yes.
Yes,
Okay.
much better.
Yay. Okay. So let me go back to share. And I might have to, oh, here. Okay.
Make sure that you mute your computer. That way we're not picking up both. It'll echo.
Thanks for accommodating us.
How do I mute my computer?
Actually, I thought you already did when I was looking at it. Yeah, you're muted.
Okay. Okay. So when I was talking to patients, I expected people to be very anxious, and I was really surprised to hear, I think I'm going to have to lower the volume on my screen because I hear myself.
Yeah, you're echoing.
Okay. I am sorry about this.
Oh no, we all understand the technical difficulties. Now I
don't
think
know
you're
how to minimize my screen now.
maybe if you stop sharing, I'll share your slides. Would that help?
Yeah, let's do that.
Okay.
Okay. Is that better? Can you all hear me?
Yes. Yeah, we can.
Okay. All right.
There's
And
no
I don't hear
echo.
myself echoing. Yay. Okay.
All right, let me just share here.
So one thing that was really interesting, I expected all of my cancer patients and survivors to be very anxious about developing COVID-19. And what I found was almost the opposite. I heard before it really came to West Virginia and was before we had the stay-at-home orders, people were really frustrated because they felt like everyone else is worried about coronavirus and it's not even here yet. Don't they know that we're dealing with a really big problem? And so they felt like what they were going through was minimized. But then when it did come to West Virginia, I heard a lot of people say things like, well, I've been social distancing anyway. I quarantine myself because I'm going through chemotherapy. I don't really go around my grandchildren. I wear a mask when I go out. So I haven't really felt like my life has changed a whole lot. I heard a lot of relief that finally other people were taking it seriously. A lot of appreciation that we are taking temperatures at the front door, that people are taking it seriously and doing what we can to ensure other people's safety. I think that if we think about cancer survivorship as a whole, uncertainty really defines that whole experience, the uncertainty of diagnosis, the uncertainty of staging, the uncertainty of what treatments, how people will respond to treatment, and then, you know, uncertainty related to is the cancer going to come back, and just living with cancer survivorship. So as a whole, I think cancer survivors were more prepared for COVID-19 than the rest of us because life has been dealing with uncertainty and living to, you know, tolerate that amount of uncertainty that now we as a population are also having to deal with. And then another interesting thing is the focus on social support and connection. So more people having Zoom meetings, more people taking time out to call people and have conversations, and really a focus on figuring out alternative ways of getting social support has been such a benefit to our cancer survivors who before maybe felt more isolated when they were self-quarantining during chemo anyway. So that's been really interesting to see. And then this idea of new normal, and I'm going to talk about that more at the end of my presentation. So next slide. I do think that there are some concerns with COVID-19 and cancer, and that is what we've seen here is a lot of efforts to delay treatment. So our navigators are calling people to get in for their appointments, and people are saying things like, well, I'll just wait and see how this all pans out, and I'll come in when it's over. So we do see delays at waiting until the treatment is over, delays in people coming in for their screenings, anger at friends and family for staying away. So I've heard a lot of people say, it's my body, it's my choice. If I want to hug my grandchildren, I'm going to do that. Why aren't people coming over? We can just sit out in the yard. So a lot of family members are being extra protective, and our cancer survivors are getting very angry at that. And one thing I think that it's important and that I found very surprising is there's a lot of stigma associated, just feeling ostracized because we have differing guidelines. So some of the churches around here have decided to open with social distancing practices in place, but they're telling their congregation, if you're over 65 years old, you need to stay home. The guidelines for reopening the state, you know, we're reopening, but if you're 65 years and older, if you have a chronic medical illness, then you really need to stay home and just be more careful and cautious. But what I think some people are hearing is there's so much stigma. I'm old, they don't want me to be around. Remember, the Nazis did that. They had different rules for other people. They can't tell me what to do just because I'm old. You know, who are they to tell me what to do? And then cancer doesn't stop for COVID-19. So we as a culture are really focused on COVID-19. People still have to come in for radiation. They still have to come in for chemo. And now they have less support here at the center than they have because they can't have their visitors. Life doesn't stop for cancer. Cancer doesn't stop for COVID. Our patients who are in the hospital having surgeries or treatment for their cancer can't have visitors. So I'm hearing things like, it was the longest week of my life. I just, you know, don't have the support that I used to have. So I think that's been really hard. And then the skilled nursing facility and the fear about COVID-19 transmission in our nursing homes, and how that's affecting just the supportive care that people can get. Physical therapy, our patients are having to have two negative tests before they're able to go to a skilled nursing facility. A lot of our home health agencies are not taking new patients right now, so it's really hard to get that supportive care for our patients. So next slide. Then our caregivers are really struggling. So they do have increased fear and anxiety about their loved one's health. What I mentioned in an earlier slide of nobody's coming around, nobody's, you know, they're really worried about me. So caregivers have a care person who has cancer. There's increased risk that they're vulnerable and they're going to get this. So a lot more anxiety, and our caregivers are receiving even less support than they ever have before. So with the social distancing and really trying to minimize risk, friends and family who might be able to come over and visit and bring meals are staying away. So they're getting less help than they ever have before. So I think more is going on our caregivers. More anxiety and anger because they can't go to the doctor visits with their loved ones. I feel so bad for our patients who drive 2 hours away and have to sit in the parking lot while their patient or while their person is getting treatment. And I think, well, how can they even go to the bathroom, and just everyday things. And then our patients are feeling guilty because their caregiver can't come into the cancer center with them. So maybe more people are driving themselves when really they shouldn't be. So there is some worry with that. Our caregivers often will put off their appointments anyway, and now often they don't even have the option because the elective health appointments are delayed, or they don't have people who can stay with their loved one while they go to those appointments. More isolation, financial concerns if they can't work, and if they can, health risks about exposing themselves to more people and what they might be bringing in the home. Like I talked before about the about just, you know, can they get physical therapy? Is home health an option? And then our caregivers who are also essential health workers, who are nurses or work in the hospital, you know, really concerned about, you know, what they're bringing home. If people do have home health, what maybe the home health workers are bringing into their home. So just a whole lot more anxiety. And probably some of the most heartbreaking is our patients who have passed away. The way that we mourn has changed. So funerals limiting people, the number of people who can come into the nursing homes for the visitation, limiting the number who can be around the grave site. Some people who have decided to postpone the memorials and then feel guilt about not honoring their loved one the way that they would like. So it really has affected people in so many different ways that I don't know that I had ever really thought about before or seen. Next slide, please. Lauren, can you do the next slide? Thank you. And then us as healthcare workers. So not only are we worried about risk for our patients, but we're having to deal with our own anxiety about risk, worry about bringing that home to our own families. And we know that risk increases with the longer contact we have with patients. So we're experiencing a lot of guilt for not caring for our patients the way that we would like to. I know that I've experienced some anger and fear when I hear patients come in who aren't taking it seriously, who maybe not really washing their hands as often and saying things like, well, it doesn't matter because if I'm going to get it, I'm going to get it. That fatalistic attitude we often see in Appalachia. Zoom fatigue. Have you all read articles on Zoom fatigue? And the idea that we can go all day and see people in person, but when we're on camera, when we're participating in Zoom conversations, we feel like we're on stage. And so that performance anxiety kicks in. It's harder to read the nonverbal communication. We can have a lot of technical problems that make communicating just a lot more exhausting. So a lot more family members and friends, scheduling Zoom happy hours and Zoom meetups. At the end of the day, we can feel exhausted and just not want to participate in that. Just increased steps in decontamination. So talking to some people who, come home from work, take off their clothes in the garage, and they immediately go in the washer, have a tote in their car that they put their shoes in. So more efforts at just maintaining the hygiene for themselves and being careful of what they're bringing in the home. And I think it's worth talking about the physical discomfort with wearing masks for a long period of time. So it sounds like whiny and complainy, but eyeglasses fog up, they're hot, your ears hurt. And we know that when we're not comfortable, it affects our mood and day to day. So I think that's definitely worth talking about. So next slide. This is a graph I found, just stepping back and looking at our response as a whole. And we know that complacency is not a good place to be, and panic and fear is not a good place to be. So an optimal response is really where we want to be in dealing with the COVID-19. So next slide. So this is a good comic, I think, and we hear people say this all the time. Well, if I'm going to get it, I'm going to get it. It's not a big deal. It's just like the flu, right? A lot of the coronavirus parties that we saw in Florida, a lot of the church services where more people got it because people are underestimating the risk. And then next slide. And then just that optimal response to keep our cases low enough to where we have available resources to really help and decrease those avoidable deaths. Next slide. So if we step back and look at pandemics as a whole, we know that when Ebola was here, that people in the U.S. were overly concerned. But with COVID-19, we see that a lack of concern leads to inappropriate social distancing. But our folks who get overly concerned live their lives in just constant fear. Spoke with somebody who worries about getting a blood clot and what happens if I have to go to the hospital and then I'm exposed to COVID-19 when they've never had a blood clot. So we do see a lot of fear and anxiety about the what ifs, the what might happen that probably won't happen. So, okay, go 2 slides ahead. And then, yeah. With the Zika virus, researchers found that folks who got their information on social media, so Facebook and just social media sites, had an increased perception of risk and threat, while getting their information on the regular news led to more protective behavior. So newspapers, TV versus what we're reading on Facebook. But we do know, so next slide, that if we read the news too much, the excessive consumption of traditional media can increase our anxiety. So it's interesting to see that during the Boston Marathon bombings, researchers found that people who spent more time watching the news, reading newspapers, had more stress symptoms than those who were physically there and directly impacted by the event. So I think it's really important to consider internet vacation and thinking about where we're getting our news and maybe limiting the amount that we're spending time reading. So next slide. And then with the Ebola virus, people who had higher rates of media exposure and a history of mental health were most distressed. So those are the folks that we probably need to look at and really provide support to now. Next slide. And then just looking at isolation, quarantine and isolation, researchers found can lead to PTSD, anger, and confusion. So we really want that to be as brief as possible, but tell people why and make sure they understand why we're doing what we're doing. And thinking about my patient who said, well, you know, the Nazis did this in Germany a long time ago, really important to provide that accurate information. So next slide. This link I have here, the Coronavirus Anxiety Workbook, is published by JAMA International, and it's a really nice free resource if you're working with folks who might be anxious about COVID-19. It has different worksheets that you can go through, but just thinking about coping skills to deal with what we're going through right now, like I said, limit screen time. Notice where you're getting your news. Notice, you know, whether this is accurate information and what effect what that is having on you. I have a patient who's, you know, allowing himself to read 30 minutes in the morning and then 30 minutes before dinner, and then that's it. But really knowing, you know, are you getting trusted information? I like this term physical distancing, not social distancing. So the importance of staying connected, even if we're 6 feet apart or over the telephone, that human connection is really important. So we're not saying don't stay away from people, but just make sure you physically distance. Notice your catastrophic thoughts. So my patient who worries about getting that blood clot and then getting, and then, you know, in her mind she's in the hospital and she develops COVID-19 and dies when she has no history of blood clot. So examine the evidence. Use thought stopping. Stop that train before it leaves the station. Get involved in distraction, other activities, rather than really just dwelling on those negative thoughts. The importance of routine and schedule, especially for folks who are home all the time. Self-care is really important, and what I mean by this is make sure that we're getting enough rest, make sure we're eating regular scheduled meals and snacks, we get some exercise, we socialize. Self-care is really important. And then there are strategies to reduce stress, like progressive muscle relaxation, deep breathing, meditation. So next slide. So going forward, worries about are we missing detecting cancer early? So what can we really do to ensure that folks are going to get their cancer screening? The question was, what can we as a Cancer Coalition do is really maybe stress the importance of getting those screenings. Here at CAMC, we worry about distress screening, who's falling through the cracks, how can we support our patients now, so what efforts can we make, what efforts can we do to make sure that our folks are getting the support that they need. Education, I think it's really important to make sure when we explain to people our recommendations, we ask what their understanding is, and we don't just make assumptions that people understand. So the one patient who talked about, just feeling ostracized, me asking her if I could give her information that I read in some of the, peer-reviewed articles with the research studies, and explaining why, those recommendations are different, it took some of that stigma away. Worry about how COVID-19 is affecting treatment decisions. So even looking at more people opting for oral chemos versus maybe other means because it limits their ability to come to treatment centers. So that's just a question. Here at CAMC, we haven't been able to meet, in groups. So we're not having any support groups right now. We're not doing our group exercise classes. When are we going to be able to meet again in person? Should we do these groups over, Zoom? And what is that going to do to our rural folks or our folks who aren't technologically savvy or don't have access? And one benefit is incorporating technology to reach our rural areas. So a lot of our folks who drive 2 hours to get here often don't want to schedule an appointment with me because they're exhausted and they want to go home or it's too far to come. And I really think if we're able to continue to do telehealth, we might be able to reach our folks more. Okay, so can you do 2 slides up? And then 1 back. Yes, thank you. This is an article, it's an opinion piece in Medscape by an oncologist who really talks about that new normal. And he said, a new normal we hear with cancer survivorship all the time, describing the reality after cancer and how life once imagined and lived has been permanently changed. And I think COVID-19, thinking about the depression and how that changed that cohort, my grandmother who never throws away a cottage cheese container because you never know when you're going to have access to another container again. How have we been permanently changed as a culture? And so this oncologist colleague said, I think medicine is going to be hit very hard. People haven't been coming in for health maintenance visits and they haven't been getting screened for cancer. We are about to see people presenting with late-stage cancers due to delays in care, and I don't think this is going to be limited to oncology. We are going to see people with more advanced disease, whether it be strokes or heart attacks, coming in too late. It's happening now, and I fear it's not going to stop. So next slide. The research on PTSD really emphasizes the importance of benefit finding. So when we're able to see the benefit, the strength, the meaning in the hard experiences that we go through, then we cope better. And so this oncologist goes on to say, before the pandemic, there was an anonymity in our society. We wore headphones on the subway looking down at our smartphones. We walked past neighbors without acknowledging them. I think we've now realized collectively just how important connection is, especially for us healthcare workers. Hopefully this translates into moments of kindness, connectedness, and the experience of having been seen and heard, that yes, your voice and your life do indeed count. So I think that's a good thought to end on, and I know I have been having more conversations with my neighbors and really meeting people more, yelling across the street. And that's been really neat. And I heard somebody say that our school-age kids are going to look back and say, well, I don't remember a pandemic. I just remember being home more often and having dinner with my family and playing board games. So I think it has allowed people to step back and think about their priorities and their values and reassess, something we often see with our cancer survivors. So, and then the last few slides are just some resources and some links. And I probably ran over my time.
Well, it is some great resources. Thank you.
And I will be sharing both speakers' slides when I send out the evaluation after the meeting.
So we have had some engaging conversation in the chat while this is going on. So I'm just going to I'm going to try to hit the high points. Charlene had mentioned, I wonder about the folks that are not wearing a mask in public. Are they in denial? Do they not understand? Do they feel like if they wear a mask, people will think that they have corona or COVID? Do they think it's okay not to wear a mask because they're not experiencing any symptoms, because they don't understand that they could be asymptomatic for so long? And then finally, she did ask, is anyone aware of any education around helping folks understand the importance of wearing a mask and kind of bringing that information forward? And so I thought that was a really good conversation to think about. I am not familiar with any education around that. I do think it's an area where things are kind of lacking. And I think a lot of folks get stuck in this mindset of like, well, I'm fine. It's not, I can't get it. It's just a very strange, it's very strange. They don't see it as, protecting themselves and others. They see it as more of an infringement of rights, is kind of what I have noticed in some of my Facebook friends post. So I don't know if anybody would like to add anything to that. I know Anna had mentioned she wasn't sure if any education was going on as well.
It did inspire me to think back on some of the work I've been doing in research around like evidence-based interventions and why we really focus on policy, systems, and environmental change now. And what I found is that if you're familiar with this thing called the G.I. Joe fallacy, which is knowing is half the battle. If you were a kid in the 80s, you heard that constantly on Saturday morning. Unfortunately, that's not true. So even with education, you can expect the population to only change about 3 or 4% of behavior change based on education alone. That's the reason why you're finding implementation science and behavior change theory to be a growing asset in science, because you need those things and to overcome barriers and systems and to put structure in place to facilitate that behavior change. I think that would be a really fascinating subject to have someone that does that sort of science maybe come and talk to us sometime. I like where that made my mind go, Charlene and Anna. Thank you.
Zach mentioned reading an article on privilege and mask wearing. And so, Zach, if you could share that with that reference with Lauren, she could maybe include that for us when she sends out the notes. I actually saw something today that said we need not confuse inconvenience with oppression. And so sometimes I think it's about challenging people's language. So, and that we can all do that very gently. It doesn't have to be sort of an in your face, but because we're inconvenienced, because it fogs up our glasses, because it's uncomfortable or hot, that doesn't mean we're being oppressed. It means we're being asked to serve our community and protect each other. And so I think all of us as coalition members can take that on as a challenge as we go forward.
Stephanie, I'll look for that and try to find the link and send it.
Thanks, Zach.
Yep.
We also had a really good comment from, it looks like Kristen. They said that maybe we should really educate about how many vulnerable people are in the community. People are not thinking about cancer patients or all those with pre-existing conditions. And when you sneeze and don't have a mask on, you're really putting them at risk. And so I definitely see that, also, I think that's a good idea. And I think that we need to find good ways to communicate that information. The only other thought that I have is, I could see some of those folks being like, well, that's their problem. They're the ones that should have to take the precautions and not me. And so that would be, it's like finding that delicate balance, and how do you address that? But I do think we have to find ways to really make it clear.
I would add that, in my Facebook feed, I see lots of messaging about the importance of masks and how it can protect others and why that's important. So I think it may vary on, kind of your focus in your Facebook feed, but I certainly have seen social media postings where that communication and education is happening about the importance and why.
Yeah, Susan, and I would say that it's what the link you had sent made me actually think of kind of what you were saying. Depending on where you are and who your network is affects the information that you receive. So information that comes out from WVU, might be really impactful for persons with higher education from a more urban metropolitan area. It may not resonate as well with people in Clay, West Virginia, or otherwise examples, Mingo County, things like that. So the way things are written, as well as the source that they come from, are going to be pivotal in spreading education in low literacy and also heavy Appalachian culture areas that we serve.
And I have a question.
Go ahead, Charlene.
I just wanted to ask a question for folks, those of you who do wear a mask. I know that anytime that I'm in public, I am sure to wear a mask. And it seems to me that it's always those people who are not wearing a mask that want to come and get right up next to me. How do you deal with that?
I wear a really scary mask.
Dirty looks.
My husband works at Lowe's, and so he's been considered essential during all this time. And so what he has done is, like, somebody will come up on him and he'll take a couple steps back, and for what people want to come up to you when they want to talk to you, and I get it, I'm guilty of it myself. But what he ends up doing is if they keep coming towards him, he's like, "Hey man, 6 feet," and that's just what he does. And so I can tell you that's what he does.
Here's another way to do it. Bring on a cough and a sneeze, and they will get away from you.
My go-to has always been, I step back and say, "You're invading my bubble."
We've had some interesting situations, like for us. So my husband works, he's a pilot car driver, so he's not always working like in Mon County. So he's actually working closer to our hometown right now. And in the middle of this pandemic, his car got hit by a tire from a very large truck on the work site. His car was just sitting, it was parked. So because of that, we had to go to Enterprise, and we had to go to the collision place and leave the car. And so the company who was responsible was just paying for it out of their own pocket. And I found it very interesting that, here in Morgantown, you can't go, most people, when you go to a store, most people are wearing a mask. Like, it's rare to see someone not wearing a mask. There's definitely more people wearing them than not. But the people that my husband works with are not wearing masks, are not practicing social distancing. He has a shared work vehicle, and he cleans it out before he gets into it every single time. Hand sanitizer, constantly. He's doing very good. He has publicly shamed people by yelling out his window at work to separate, which I'm very proud of him for. But I noticed, because I haven't been around these people, so I noticed when we went to the collision place and the guy that was working for their company came to pay or whatever, talk to the collision place. As soon as he got out of his car, he rushed his hand out to shake Aaron's hand. And Aaron was like, "No, man, I'm gonna have to just elbow bump you." But that is just the difference in, where we are from, a very rural area in West Virginia that's definitely not as populated as Mon County or Kanawha County or Cabell County. It is a very different world there. You can walk into the Walmart or go in public places in Wetzel County, and it is rare to see. There are definitely way less people wearing masks. And the field that he works in, it's not common. I mean, the company posts signs everywhere that practice social distancing, but then they're doing other things that contradict that. So I think it has a lot to do with where we are, and I think probably this article Zach has on privilege and practicing those things has a lot to do with why some people aren't practicing.
I love how engaged we've gotten in this conversation, but I have two things happening right now. I have an alarm going off that's saying I promised you a bathroom break, and that is about 10 minutes late now. And I have a cat that's reminding me that I promised to feed her during that break. So, Lauren, since we're running over, how do you want to do the break?
So we're just going to come back at 12:05, and we'll shorten our report out just a smidge, and we'll shorten our breakouts just a smidge. I want to give everybody enough time to have some lunch, and I have a fun poll that I'm going to throw up while we're on the break, and don't have Zoom fatigue. Turn your video off. Take a break. We'll see you at 12:05.
But stay logged in, right?
Lauren,
Yeah.
before people go, I just want to let you know that I'm going to be logging off because I'm presenting to a national group on the work of the Cancer Coalition at noon today. So there are about 140 people, and I'm going to highlight some of our